Welcome everyone to the FAPESP research webinar. Welcome everyone to this FAPESP research webinar in another session from the COVID-19 series. I'm Professor Francisco Laurindo from the University of São Paulo School of Medicine, and in this video representing FAPESP as a member of its senior advisory board. I have the pleasure now to give the microphone to our scientific director, Professor Luis Eugenio Melo, who will give you the welcome address.
Thank you, Laurindo. It's a pleasure being here at this event. As we all know, COVID has hit us hard, and it has been over a year that we have been suffering of its consequences. And in addition to the contagion and the infection itself, we now experience the understanding that it has long-term consequences, which we do not fully know as of yet, and towards which we should share knowledge and share understanding in a way that we may find better ways to diminish the burden of these long-term consequences. So it's with great pleasure that I participate on this event. Thank you, Laurindo.
Thank you, Luis. And today our focus is on long subacute COVID-19. We all know that COVID-19 is was an unknown disease until 1.5 years ago, and we keep getting new pictures coming in, and one of the major manifestations has been this puzzling picture of long and subacute COVID. So patients who have a kind of moderate disease, they exhibit a long stage of disease with symptoms like severe joint pains or muscle pains or neuropsychiatric manifestations and cardiopulmonary manifestations and several others. And the etiology of this remains puzzling. And there are several theories, but it appears that understanding the immunological outcome of COVID is important to get to the key of how subacute COVID-19 evolves, and also several other mechanisms like virus persistence or immunological autoimmune reactions or virus persistence in some specific cells can be possible. So a multidisciplinary approach is really needed, and also it's difficult to take care of these patients because they all have several multisystemic manifestations. So I think it's very opportune that we discuss the long and subacute COVID-19 today. And without further ado, I will move on to the first speaker. And before I do this, I have some practical information. So everyone who wants to send questions can do this in English or Portuguese to the following email: live, L-I-V, live, @fapesp.br. I'll say it in Portuguese. Live, L-I-V, @fapesp.br. This email here. And I would also need to inform you that this webinar is going to be recorded on Agência FAPESP YouTube channel. It's my pleasure to introduce Professor Regis Goulard Rosa from Hospital Moinho de Ventos, Porto Alegre, Rio Grande do Sul. And he will talk to us about long-term outcomes after hospitalization for COVID-19 in Brazil. Professor Regis, thank you so much for accepting talking to us. And I know you must be very, very busy with this, but it's nice that you found time to talk to us today. Thank you.
Hello, everyone. It is a great pleasure and honor to speak here today about an important topic. I'm going to talk about some preliminary data of the Brazilian study on quality of life and long-term outcomes after hospitalization for COVID-19, the Coalition 7 prospective cohort study. Here are my conflicts of interest. One major problem related to COVID-19 is the fact that infected patients may develop a multifocal and progressive pneumonia. And an important part of hospitalized patients may require prolonged mechanical ventilation and other important treatments to give support for organ failure or organ dysfunction. And in this context, possible influencing factors on long-term outcomes are organ damage or failure, mechanical ventilation, medications, sedatives, benzodiazepines, for example, neuromuscular blocking agents, steroids, and immobilization. But we must pay attention also for specific COVID-19 factors such as endothelial dysfunction, immune dysfunction, activation of autoimmune response, persistent inflammation, ongoing immune stimulation from reservoirs of persistent infection, and also residual damage of ACE receptor positive tissues such as the lung tissue. Recently, the WHO recognized long COVID or the post-COVID-19 condition as a priority for recognition, research, and also rehabilitation. Emergency codes of post-COVID-19 were created for the ICD-10 and ICD-11 in order to allow surveillance of cases. Also, the care after acute illness was incorporated into the WHO COVID-19 clinical management guideline. And importantly, the WHO created working groups focused on standardization of case definitions and outcomes in order to facilitate research across the world. Our objective with this study is to assess long-term outcomes and also associated factors among survivors of hospitalization for COVID-19 in Brazil. This is a prospective cohort study nested in 5 randomized clinical trials originally designed to assess the short-term effects of different potential treatments for COVID-19 among hospitalized patients across over 50 centers in Brazil. Adult survivors of hospitalization due to COVID-19 are followed up for up to 1 year after enrollment in order to assess health-related quality of life and also other important long-term outcomes. We are enrolling patients aged 18 years or older requiring hospitalization due to COVID-19 and meeting eligibility criteria for Coalition 1, Coalition 2, Coalition 3, Coalition 4, and Coalition 6 randomized clinical trials. Exclusion criteria include death during hospitalization, absence of telephone contacts, and also absence of proxy for patients with communication difficulties. Briefly, the Coalition 1 randomized clinical trial assessed the effects of hydroxychloroquine among hospitalized patients with less than 15 days since symptom onset, needing either no oxygen or up to 4 liters per minute of supplemental oxygen. The Coalition 2 randomized clinical trial assessed the effects of azithromycin among hospitalized patients with less than 15 days since symptom onset, needing oxygen supplementation higher than 4 liters per minute or oxygen supplementation through high-flow nasal cannula, non-invasive ventilation, or mechanical ventilation. The Coalition 3 trial assessed the effects of dexamethasone among hospitalized patients needing mechanical ventilation within the first 48 hours of meeting criteria for moderate to severe ARDS. The Coalition 4 trial assesses the effects of anticoagulation therapy using rivaroxaban or heparin among hospitalized patients with less than 15 days since symptom onset and an elevated D-dimer. And lastly, the Coalition 6 trial assessed the effects of tocilizumab among hospitalized patients with confirmed pneumonia due to COVID-19, needing oxygen or mechanical ventilation, and at least 2 abnormal inflammatory tests. Our primary study outcome is the 1-year utility score of Euroqual 5D3L questionnaire. Our secondary outcomes include survival, major cardiovascular events, rehospitalizations, physical functional status according to the instrumental activities of daily living of Lawton and Brody, dyspnea according to the MRC dyspnea scale, need of long-term ventilatory support such as oxygen and non-invasive ventilation at home, symptoms of anxiety and depression according to the hospital anxiety and depression scale, symptoms of post-traumatic stress disorder according to the impact event scale revised, self-rated health according to the Euroqual 5D3L visual analog scale, and also return to work or study. In this presentation, we stratified analysis according to the need of mechanical ventilation during the hospitalization as a proxy of severity of COVID-19 episodes. And we are going to show some crude models and also some adjusted models for important covariates, such as state of origin, age, and also comorbidities. So patients who survived hospitalization for COVID-19 and were included in the coalition trials are followed by means of structured and centralized telephone interviews performed by trained researchers at 3, 6, 9, and 12 months after enrollment. Importantly, this is an ongoing study, and I'm going to show you some preliminary data. For this analysis, 1,006 patients met eligibility criteria. Of these, 931 were assessed at 3 months after enrollment, and 776 were assessed at 6 months after enrollment. Here I show some baseline characteristics at the moment of hospitalization, at the moment of enrollment for coalition trials. The mean age of our population was 52 years, 61% were men, and the most common comorbidities were hypertension, diabetes, and obesity. The median time from symptom onset to enrollment was 7 days. And the score on 7-level ordinal scale of WHO at enrollment was as follows. 38% of patients were hospitalized and not receiving oxygen at the moment of enrollment. 46% were hospitalized and receiving oxygen. 4% were receiving oxygen by high-flow nasal cannula or non-invasive ventilation, and 10% at enrollment were receiving mechanical ventilation. During the hospitalization, 23% of our patients needed mechanical ventilation, with a median length of mechanical ventilation of 11 days. And the median length of hospital stay for the entire cohort was 9 days. The cumulative all-cause mortality at 6 months was 6.9% for the entire cohort, the blue bar. However, after stratification according to the mechanical ventilation needs during the hospitalization, we can see that patients who needed mechanical ventilation had a cumulative mortality rate at 6 months of 24%, against only 2% of patients who did not require mechanical ventilation, a difference that is clinically relevant and also statistically significant, even after adjustment for important covariates. The cumulative rate of rehospitalization 6 months after enrollment was 16% for the entire cohort. But again, patients who required mechanical ventilation had a significantly higher rate of rehospitalization in comparison to patients who did not require mechanical ventilation during hospitalization. 40% versus 10%, a difference that is also statistically significant even after adjustment for important covariates. Regarding physical health, we can note that patients who required mechanical ventilation, the orange line, had a significant, clinically significant and also statistically significant decrease in their physical functional status at 3 months in comparison to the period of 1 month before the hospitalization for COVID-19. And after 6 months, this physical functional status, the median physical functional states of these patients who require mechanical ventilation was still different from the baseline. Regarding mental health, at 3 months, 22% had anxiety symptoms, 17% had depression symptoms, and 14% had post-traumatic stress symptoms. Interestingly, patients who required mechanical ventilation had significantly higher prevalence of PTSD symptoms in comparison to patients that did not require mechanical ventilation. At 6 months, we have similar data regarding anxiety and depression. 22% of patients with anxiety symptoms and 19% of patients with depression symptoms. And at 6 months, we had 11% of our cohort with symptoms of post-traumatic stress. The self-rated health, according to the EQ-5D visual analysis scale, was 73% at 3 months for the entire cohort and 80% at 6 months. However, patients who required mechanical ventilation had significantly lower scores of self-rated health in comparison to patients that did not require mechanical ventilation at 3 and also after 6 months. And mechanical patients who required mechanical ventilation also had significantly lower rates of return to work or study at 3 and also at 6 months in comparison with patients that did not require mechanical ventilation during hospitalization. Concluding, among survivors of hospitalization due to COVID-19 in Brazil, in the months following discharge, the mortality rate is high, especially among more severe patients that required mechanical ventilation, for example. Rehospitalizations are common. The burden of physical and mental health disabilities is meaningful, and mechanical ventilation need seems to be an important predictor of poor long-term outcomes and may be useful for strategies of screening patients at increased risk. Of course, we have a lot of research gaps and priorities in order to know this new disease we need to confront. First, we need a common definition and a core outcome set in order to allow comparability across different studies and also an effective summarization of data. We need also to assess non-severe cases in order to separate the effects of critical illness disabilities from the effect of COVID-specific mechanisms for long-term disabilities. We need to establish natural causes of long COVID and also phenotypes and risk factors. We need to develop prediction tools and also to assess pathophysiological mechanisms, and this is very important. We need to know pathophysiological mechanisms in order to develop effective treatments. And also we need to assess cost-effective treatment and rehabilitation strategies for long COVID. Thank you very much. It was a great pleasure to be here today.
Thank you so much, Professor Regis. It was a very interesting presentation. And as I told you, we will have a discussion at the end, although we already have some questions in the WhatsApp, but I will leave them for the round of discussion. And now we go on, and I am quite pleased to introduce Professor Catherine Hough, who is Professor of Medicine and Chief from the Division of Pulmonary and Critical Care Medicine, Oregon Health and Science University. And Professor Hough will talk to us about 1 month outcomes after hospitalization for COVID-19 and next steps, the United States experience. Thank you so much for finding time for us in the middle of your very hectic agenda, and we are very pleased to have you here.
Fantastic. Well, thank you so very much for inviting me. It's a real honor to be here today. I've already learned so much. Congratulations to the speaker before me for that work. It is just amazing and is going to teach us so very much. So let me set up my screen here. All right, does that look okay?
Yes.
Fantastic. All right, well,
Yes,
thanks again. I'm excited to share with you the study that we've designed in the United States to look at observational experience with COVID and post-COVID, and to share just a little bit of early data, although I don't have nearly as much as we've just seen. Just quick disclosures, none of this work is funded from industry. It's all from the National Institutes of Health in the United States. And I do have to take a moment to disclose how fortunate I feel to live in a place that really has not been hit very hard by COVID-19. I'm in the left-hand corner of the United States in Oregon, where the cases are the lowest in all of this country. So I just feel so lucky for that. So here's the outline. I'll start just by telling you a little bit about the PETAL network and CORAL, the study we've designed. I'll go into more detail for the Blue Coral study and then end with a few next steps. So the PETAL network maybe aspires to be like BrickNet, which I admire very much. The PETAL network is funded by the National Institutes of Health and the National Heart, Lung, and Blood Institute of the United States, and was put together about 8 years ago to be a clinical trials network with the goal of preventing, treating, and improving outcomes of adult patients who have ARDS, the acute respiratory distress syndrome, or who are at risk for that. Our structure is 12 clinical centers across the United States, with each of which have additional contributing sites. So we have 57 medical centers participating, covering all parts of the United States. The leaders of the PETAL network are critical care, pulmonary critical care, and emergency medicine physician scientists. And so, like everyone else, in early March of 2020, we stepped away from our clinical trials in ARDS to say, what are we going to do about COVID? And we had the goal of conducting rapid turnaround studies to inform both science and clinical practice. And we formed 2 new committees within PETAL, one to do COVID-19 clinical trials and another to do observational research. So it's the observational research group that I'll talk about today. This is led by me with a focus on epidemiology, and my colleague, Dr. Becky Barron at Brigham and Women's Hospital in Boston, who studies the pathogenesis of ARDS. And so we created a study with the goals of rapidly gaining and sharing information about COVID-19 in hospitalized and critically ill patients, since this was the structure of the PETAL network. We obtained 1 year of funding from the government and put together what we call the COVID-19 Observational Study, or CORAL. There are multiple projects within CORAL. The first was a retrospective study we called the Repository of Electronic Data, or RED CORAL. The second looked at hospital procedures to adapt and respond to the pandemic, or the state of emergency activation, which we called C-CORAL. And mostly I'll focus on the biology and longitudinal epidemiology, or Blue Coral. So, just a quick note of where we've been. So Red Coral was led by Dr. Ethan Pelton, who's from Utah. And this was a cohort of 1,500 patients, all hospitalized at US hospitals in March, or the first day of April in 2020. These patients were enrolled consecutively by site, and the goal was to describe their characteristics, their treatments, their hospital course, outcomes, and risks for death. And so this work is under review right now. This map shows actually just how few cases we had back in early March. This is what's called a chloropleth that was put together by Dr. Bo Zhao at the University of Washington. Here you see county level maps with the case rate in the degree of red, but most importantly is just seeing where the PETAL sites are across the country. So each of these black dots represents at least one PETAL site. For those of you who don't know where Portland, Oregon is, I'm right here in Oregon State. So the next study was called C-CORAL, and this work is ongoing. The first paper was published in Critical Care Medicine a few months ago, led by Dr. Kasum Matthews at Mount Sinai in New York. And this was a survey-based study looking at the variation of the first hospital responses to COVID in the United States. But I promised we would focus on Blue Coral. So let me tell you about that. Blue Coral has the goals of characterizing the severity, the clinical course, and the host response in patients hospitalized with COVID-19. with goals of identifying risk factors for hospital mortality, for respiratory failure, prolonged mechanical ventilation, and then, important for today's topic, persistent disability. We also aim to describe care processes and resource utilization, and then importantly, to define the post-acute outcomes after COVID. So the study design is a prospective observational longitudinal study, including hospitalized patients at all of our pedal hospitals who present with fever or respiratory signs and symptoms and have positive molecular tests for SARS-CoV-2. This study requires informed consent, and we try to get patients early in their course of hospitalization. Our target enrollment is 1,500. We're using the same protocol that was done in the Red Coral study, that retrospective study, for collecting medical record data and images. But then we've also added a lot of prospective assessments that I'll describe. So first, at the time of enrollment, we're collecting baseline health-related quality of life using the EQ-5D. We are asking about disability with the same ADL scales we just heard of, the basic and instrumental ADLs, activities of daily living. We're asking about frailty and about finances of the patient at the time of presentation. Then throughout the hospitalization, we have standardized clinical lab collection, including CRP, ferritin, D-dimer, coagulation studies, troponin, and a metabolic panel. We are prospectively collecting biospecimens for a repository, including blood for plasma, DNA, and RNA that we do at study enrollment and then at multiple time points in the ICU stay. When available, we're also collecting tracheal aspirates, bronchoalveolar lavage fluid, and urine. And then after patients survive to hospital discharge, which fortunately most do, we are conducting telephone follow-up at 1, 3, and 6 months. We're doing the same assessments that we did at the time of enrollment for health-related quality of life, disability, frailty, and financial strain. We are then doing a more extensive look at cardiopulmonary symptoms. We're looking at depression with the PHQ-9, anxiety with the GAD-7, and cognitive function using the Montreal Cognitive Assessment, or the MoCA, as well as the Hailing Sentence Completion Test looking at executive function. We're also asking many questions about healthcare utilization. So let me tell you where we are right now. Of the 1,500 patients, that is our full target enrollment, just this morning, we were at 1,280. So we are quickly approaching. So we don't have complete data on all these patients at this time since we're prioritizing enrollment over data collection, but I can give you a few snapshots. So of about 1,200 patients, we're seeing that there's a slight male predominance with 54% of the patients are male. Less than half of our patients are white and non-Hispanic, with 29% Hispanic or Latino, 18% Black, and 9% Asian, other, or unknown. And then again, there's missing data for the hospital course, but it looks like around 27% of patients will have been in the intensive care unit, 14% on mechanical ventilation. Our length of stay looks very similar to what we heard in Brazil, with a mean of 9 days and a standard deviation of 18, but a very low mortality across the overall cohort of 7%. So as far as the post-hospital follow-up, this is where we are. So of around 1,200 patients that we have eligibility data, we've excluded a little over 300. So about a quarter of the cohort is excluded. The most common reasons are death, either in the hospital or before the 1-month follow-up time point. A few patients don't speak English or Spanish or are homeless, but we've lost very few for those reasons. But we elected to not include in our follow-up study patients with significant baseline disability. And so 214 patients so far have been excluded for that reason. And we've defined this as being dependent in 4 or more activities of daily living. So we've had 872 patients eligible to date and more every day. At 1 month, we've finished 578 surveys, just 29 of these by proxy. 120 are still waiting to happen, and 180 have been suspended. At the 3-month time point, we've completed 339. And at the 6th-month time point, we're just getting started there. We've done 56 so far. So we just recently had accepted for publication an early look at some of our 1-month data. And so I'd love to share those with you. This work has been led by Dr. Jack Awashina at the University of Michigan and many others from our choral committee that you see here. So the objective of this was to measure COVID-19 patients' symptoms, disability, and care needs 1 month after hospital discharge. This was a pre-planned early analysis, including patients who were hospitalized between August of 2020 and January of 2021. And then we included the first 253 patients who completed their 1-month post-discharge surveys in Blue Coral. This is how we got to those patients. So there were 647 patients enrolled in that time period. We lost 54 who died in the hospital. Then of the 588 who remained in the study and were discharged alive, again, most of the patients who did not stay in the cohort were excluded for disability or cognitive impairment, 115 patients. So 460 patients were eligible for that 1-month follow-up in our time period for this look. We missed 64 of those, and there were still 143 that were waiting for their surveys to be done when we closed for this early look, leaving us with 253 patients. So who were those patients? We don't have all of the details yet, but this is what we know. They look quite a bit like the COVID population with a median age of 60, a male predominance, as we've described before. Most of these follow-up patients, 54%, were white, non-Hispanic, only 9% Black, and almost a third Hispanic Latino. The length of stay of this first group was quite a bit shorter than the overall population, and I think that most of these patients were not critically ill. If we look at where they went at the time of hospital discharge, 78% went directly home. Of those 15%, or another 15% went home but required ongoing services, and then very few patients were discharged to continued institutional care. So when we look at what was happening with heart and lung symptoms, we found actually that most patients had new or worsening cardiopulmonary symptoms at 1 month. We see at the bottom of this table here that 55% of patients had at least one new cardiopulmonary symptom. We used the Kansas City cardiomyopathy questionnaire and an airways questionnaire to come up with these questions. So for example, we frequently found patients had cough, breathlessness, difficulty getting around the house because of chest trouble, rapid heartbeats, and chest pain were some of the common symptoms. Also notably, 1 month after hospital discharge, still 16% of patients were continuing to use supplemental oxygen at home. Now, our focus was really on disability. And as I said, we assessed 14 basic and instrumental activities of daily living, and we found that over half of patients had new limitations in these ADLs. These were associated with age and length of stay, and a little less common in the Hispanic Latino population. Interestingly, many of the patients with significant disability were discharged home without any services at all. And in this histogram, you see the distribution of the number of new or worsened disabilities across these 14 ADLs. In the brown bar, you see patients who are discharged home without services. And then in black, the patients who went home with services. And you see that while many patients had no new disabilities, that most had at least one new one. Many had 7 or more. And that across these categories of disability, most patients were going home without services to help them with those new problems. One of the other questions that we asked was sort of a COVID-specific return to baseline health question. And so we asked, on a scale of 0 to 100, how recovered are you to your pre-COVID state? And so our median response was 80 with a IQR of 64 to 95, but we found 17% were still less than 50, saying that they weren't even halfway recovered 1 month later. We found this perception of return to baseline state was lower for women, for older patients, for longer hospital stays, and those with more symptoms. And then in this graph, we tried to show what Jack and I thought was very interesting, that we seem to be measuring different things with symptoms, with disability, and with perception of recovery. So let me show you this figure. Here along the bottom, the y-axis is how recovered a patient reports being from 0 to 100%. And then for each, in the different colors, we're telling you, do they have no symptoms and no disability in green, new symptoms but no disability in red, no symptoms but new disability in blue, and then purple is both new symptoms and new disability. And you see that at all of the recovery levels, you find patients in each of these groups for the most part, which again is quite interesting, that somebody could perceive themselves to be almost completely recovered and yet still have symptoms and or disability. So we asked questions about return to work and financial strain. We found that 55% of our patients reported a drain on their finances, which was moderate, severe, or extreme for about half of those. Also, about half of patients reported having used up all or most of their savings because of their hospitalization. And this was particularly true amongst our Black and Hispanic Latino patients. We also found that 38% of family members had to take time off work to care for their patients after hospitalization, and 20% had to change their own work. Now, in some very rough data, kind of looking across domains, I just wanted to sort of show a broader view of what that experience is looking like at 1 month. So this is a composite of symptoms and disability across all of those different scales that we measured. Again, this is that question about degree of recovery, where 85% of patients said they weren't recovered at 1 month. Using that ADL scales, 65% had some degree of disability, 36% with fatigue, 58% with some shortness of breath or cardiopulmonary symptoms. A full 63% had significant cognitive trouble, and 30% with poor sleep. And those were some of the more common symptoms. Interestingly, when we follow those patients, now just 65 of them at 3 months, we found very little change in perception of recovery, in disability, and cognitive impairment between 1 and 3 months. So a quick summary then for Blue Coral. Our enrollment is ongoing. We have just about 200 patients left to enroll. We certainly have a lot left to learn about our hospital course, the biology, and the post-hospital outcomes. Looking at that 1 month data, we're certainly seeing that most patients haven't recovered with persistent symptoms, new and worsened disability, and financial strain, and that disability, cognitive impairment are persistent for most patients at 3 months. So what are the next steps? As I mentioned, we will continue enrollment for Blue Coral. We're hoping that within the next few months that we'll complete enrollment. By the fall, we'll complete our data entry and cleaning and do all of those biomarker analyses that I mentioned. And then in the winter and spring to follow, we'll finish up our 6-month post-hospital assessments. We'll be ready to share our data and biospecimens and to disseminate the results. Now, in addition to the studies that I've mentioned, we've added an extra piece onto Blue Coral that we're calling Fire Coral. This is the functional imaging and respiratory evaluation. And so this is taking 80 patients who are already in Blue Coral and inviting them to come back to our medical centers at 3 and 6 months so that we can assess pulmonary function, chest imaging, and functional status. We'll also be collecting blood to look at convalescent samples to add to our biorepository. And our first patient should be studied this month. And this is just a quick look at all of the different investigations that they'll have done. Here we have in the hospital is the enrollment in blue coral, the telephone follow-ups, and then in orange, we're seeing those fire coral assessments. So biospecimens, CT scans, spirometry, lung volumes, diffusing capacity, 6-minute walk tests. And then a subgroup of those will be followed again at 6 months. So we're eager to be able to share those data soon. So I just wanted to thank the dozens of contributors to these coral studies, and of course to thank you very much for your attention.
Thank you so much, Professor Hough. This has been a very interesting set of presentations of new published data, which I really thank the speakers for sharing with us. And now we move on to a very important issue, which are the neuropsychiatric manifestations of disease. And I have the pleasure to invite Professor Geraldo Busatto, who is Professor of Psychiatry at the University of São Paulo Medical School. And he will talk to us about neuropsychiatric implications of long COVID-19. Thank you for accepting and sharing your data with us.
Thank you, Francisco. It's a great pleasure to be here and take part in this very important symposium representing our medical school at the University of São Paulo, here in São Paulo City, and also Hospital das Clínicas, attached to our medical school. Just to give you a little bit of a background on our institution and what has happened regarding COVID-19 since last year. Faculdade de Medicina and Hospital das Clínicas, they jointly form our academic health system, and the hospital is the largest hospital complex in Latin America with 2,400 beds. And from the beginning of 2020 through September, from February to September, the Central Institute of our hospital was converted into a fully dedicated COVID-19 in-hospital facility with 900 beds. There had to be a complete re-architecture of the hospital complex, exchanging patients with all the other institutes. There are 8 institutes at our medical school, and this allowed us to receive a large number of patients with moderate to severe COVID-19 over that period of time. And this is what I'm going to talk to you today is the some glimpse on the observational studies using data from those inpatient admissions during that period of time. There were lots of studies conducted specifically by specialized research groups, but we had also 3 institutional initiatives, if you like. And what I mean here is that a number of initiatives that had not been undertaken before. And so, of course, there was a lot of strain with COVID-19, but this represented also an opportunity for change for our institution in terms of research, infrastructure, and logistics. One of the things that we did was to organize data from the hospital admissions for the first time, and we did that for the total of over 1,300 subjects with lab-confirmed COVID-19. And this was an effort to extract data from electronic health records and also get people from different research groups collaborating with each other and sharing their data to organize this repository of clinical and demographic data. The second thing, which I'm going to talk to you about, is a program for reassessing patients at 6 to 11 months after discharge. And the third initiative is a biobank with sero and plasma samples collected both during hospital admission in approximately 900 patients and at the follow-up assessment in another 750 patients. I shouldn't say another 750 patients because we have about 500 patients with biobank store data from both the admissions and the follow-up assessment. And this is all overseen by a steering committee designated by the board of directors of the hospital and the dean of our medical school. And today I'm going to concentrate on the multidisciplinary reevaluation of patients. This is, of course, a huge effort involving several different research groups and clinical groups. I'm trying to acknowledge all of them here. In the middle, you see the people from the psychiatry and neurology departments. I'm making this presentation on their behalf. In terms of financial support, I would have to cite FAPESP here because although we haven't had direct financial support for this initiative, all of the people who have worked on research and are involved in this initiative over the past few months, they have strong support from FAPESP. And the other important thing to mention here is that for the first time, there was a crowdfunding scheme, both for assisting the clinical aspects of COVID-19 treatment at the hospital, and also some funds for research. And this data that I'm sharing with you today, they have been collected with the support from this crowdfunding scheme, which we call HC Convida. Okay, before I move to psychiatry, I have to mention three aspects, specific aspects of our multidisciplinary assessment. These are somehow different from studies published elsewhere to date. The first difference is that we brought together specialized teams for in-depth assessments from each area of interest. So in addition to yes or no symptom questioning, several scales were brought by these teams. And here in number 2, I cite that the eligible subjects, which were all hospitalized patients with age greater than 18 years, they were invited for in-person visits to be seen by these specialized teams. So this is different from making telephone assessments. So we had all these people invited to come to hospital, and together with the scales, we also had the opportunity to do some objective assessments, including psychiatry and neurology. We had 2 centers collecting data, and with that we could divide patients between those who had less severe disease, who did not require ICU stay, intensive care unit treatment, and a group with who had stayed in intensive care units with more severe cases of COVID-19. With that, we could differentiate the assessments for the patients and also increase the number of patients evaluated at each week. This is a flow chart showing the trajectory of participants. We had, in terms of surviving patients from the admissions, approximately 2,000 potentially eligible patients, after excluding those who had lack of mobility to come to hospital, end-stage cancer or dementia. We consecutively invited all individuals and expected that we will have a rotation rate of at least 800 subjects. As I said before, we had 2 centers, a patient who did not require intensive care during the in-hospital admission, and patients who stayed in intensive care during the hospital stay. And we, for those subjects who had symptoms that could indicate pulmonary dysfunction, more clinically meaningful pulmonary dysfunction, they were invited for a second visit, which was similar to the visit that we organized for the patient who had stayed in intensive care units. This is the demographics for the sample that accepted to come to hospital again for the reassessment. We had 882 patients. I should say here, make a correction that we had 757 patients who agreed to come in person. And because we wanted to increase the numbers, we also did teleconsultation with another 15% of patients, composing this total of 882 patients for this study overall. These are the hospitalization characteristics of the patients. It's more or less similar to what has been shown by the previous speakers, but I would call attention here to one very important detail at the bottom of the table, is that we had from those subjects who agreed to take part in this follow-up assessment, 2/3 who had treatment in intensive care units. So this is really a sample of patients with quite severe COVID-19. Of course, we had the opportunity, due to the use of electronic medical records and the input from the research groups that working during the hospital admissions, we could compare the patients who agreed to take part in the follow-up assessment and those who did not come for the assessments. And as you can see, in terms of demographics and comorbidities, they are similar to each other. But I call your attention to the bottom of the table, and you will see that the patients who did not come for the follow-up assessments, they had less severe disease. If you look at the duration of hospitalization, duration in stay in intensive care units, need to use intensive care units, need for intubation as well. So in other words, we really had a severe sample of patients who came back to hospital for the reassessments. Before I move to psychiatry and neurology, I just wanted to show you a glimpse of the frequency of several symptoms. You will notice that we have not included here, of course, psychiatry and neurology, but that's for the rest of the presentation. And we have a huge number of patients presenting symptoms at the follow-up assessment. The mean number of days is 218 days after hospital discharge. So the mean is more or less 6.5 to 7 months after discharge. And if we count the number of symptoms, we get a picture with that is at the top range of the studies that have been published so forth, that evaluated patients at about 6 months after hospital discharge. There are studies showing that 85% of patients approximately may complain of persistent symptoms. And we had 89.3 subjects presenting at least one symptom, and tiredness was the most frequent symptom reported by those patients. One important detail here is that we adjusted these frequencies for the presence of symptoms before COVID-19. So these are incident symptoms and persistent after 6 months from hospital discharge or more. Well, moving then to the Neo-Psychiatric Manifestations, there are data in the literature showing an increase in frequency of those symptoms, and there are several possible influences on the emergence of those symptoms in cases of moderate to severe COVID-19. These have been already outlined nicely by the previous presenters. And it's very important to understand the nature of these features and carry out analysis trying to tease apart the separate influences on their emergence and persistence. So what we did then was to add a detailed neuropsychiatric assessment of symptoms for this sample that I described earlier. And the aim is to confirm and extend findings reported previously in other studies, and also to investigate relationships with potential predictors. And for this presentation, I'll be talking about events during hospitalization and also psychosocial stress related to the pandemic. I will not go in detail through all the assessment instruments. Some of them are similar to the instruments that have been described by the previous presenters, but as you can see, it's a deeper, more detailed assessment of psychiatric, neurological, and cognitive features related to COVID-19. And this is a chart showing the complaints of patients related to psychiatry and neurology, psychiatry and cognition. As you can see, about 60% of patients referred symptoms that persisted after discharge. These symptoms are very much interrelated. There is a lot of overlap. In other words, the person that complains of memory loss also complains very frequently about insomnia, maybe anxiety and depression. And again, this is all adjusted for the presence of symptoms before COVID-19. Because we use the structured interviews, we could categorize the diagnosis of the patients in terms of psychiatric disorders. And these frequencies that you see here in the second column, they are all higher than what you would expect at the age ranges of the population investigated in our study. The types of disorders, they are quite varied. The same similar rate of post-traumatic stress disorder, as you can see here, and also high rates of delusions and hallucinations or psychotic symptoms. We also assess changes in patterns of substance abuse. The only notable thing here to be mentioned is the increased use of sedative and hypnotics, which is expected due to frequency of anxiety and insomnia in this population. I have here two selected tasks, the cognitive tasks from the battery that we used. And as you can see, the performance of patients were worse for this task here, trail making A, which is a sustained attention task in all age ranges. The comparison with the norms for the Brazilian population, you can see that the performance is worse, especially for those who are at a higher age. But for verbal fluency, a frontal lobe task, if you like, the performance is not so different. So this is just a flavor that the deficits shown by the patients, they are not uniform. So some areas of cognition may present more deficits than others. This is the questionnaire used for assessing neurologic symptoms. You can see that the most prevalent one was headache in approximately 40% of patients, and then paresthesia with just over 20% of patients complaining of persistent paresthesia. And to end up my presentation, I will talk a little bit about the regression analysis that we conducted to search for significant predictors of neuropsychiatric outcomes at the follow-up assessment. And we adjusted all the analysis for the demographics, and we assessed the influence of comorbidities, length of hospital stay, intensive care unit stay, intubation, hemodialysis, and frailty prior to COVID-19. And the analysis that I'm going to show you at the end of this presentation now, they are separate for each domain. First, the symptoms assessed with the screening questionnaire for neurological disorders, then psychiatry and cognition. The two symptoms that showed a significant correlation with hospitalization events were weakness and gait impairment. And you can see here that there's an association with need for intubation, duration of hospital stay for weakness, and intubation for gait impairment, and also a relationship with the presence of the diabetes as a comorbidity. For psychiatric symptoms, we had no significant associations with any of the hospitalization events that we evaluated. And also, we assessed the psychosocial variables that we asked regarding financial loss, regarding loss of loved ones, and we also found no relationship with these psychosocial variables. In terms of cognition, again, most of the cognitive tasks that we employed, that we selected 2 here, they had no significant correlations with events during hospitalization, apart from a finding of better performance in the verbal fluency task in patients who underwent hemodialysis. We don't want to make too much of this correlation here because it's not a very large sample who underwent hemodialysis, but this is important to show that we didn't find worse performance in those subjects due to the intensity of or need of care for these patients during hospital admission. To conclude, our data show that at the long term, from 6 months onwards, you have a range of persistent neuropsychiatric manifestations following moderate to severe forms of COVID-19. And there are differences in the pattern of manifestations, and they may emerge under different causal influence. So musculoskeletal manifestations that may suggest neurological impairment, they were influenced by hospitalization of events, whereas psychiatry and cognition did not show such associations. We could actually speculate that if we don't show associations with hospitalization events, if we don't show associations with psychological stress, maybe these psychiatric and cognitive manifestations, they could be due to effects, indirect or direct effects of the infection on the brain. But this is something to be discussed and speculated in at the moment. We can do more than speculate. This deserves further investigation. And there are several analyses underway. For psychiatry, what I showed you is an interim analysis. We are repeating the analysis for the overall sample. We are doing a series of other investigations, taking advantage of the fact that we have a multidisciplinary team working on different aspects of disease. So, for example, we can look at relationships between anosmia and neuropsychiatric symptoms. This can be informative, and this can also help in the organization of the services that these people will need to be cared for. I thank you very much for your attention and the kind invitation to take part in this important event again. Thank you.
Thank you so much, Geraldo. This was a fantastic presentation, and I cannot help saying that as a basic investigator, I think that what the team from our hospital did is equivalent, in my view, to publishing a paper in Nature, let's say, like the tremendous challenge for organization, transforming the hospital in a 900-bed for COVID. And it's not by chance that you have such a nice sample of cases to look at, and that was real hard work from many people, and you, I know, was very much involved, and many others. So thank you so much for sharing this data with us.
Thank you.
And now we move on to a very interesting talk about the mechanisms that underlie the immune response to COVID-19. And I'm pleased to invite Dr. Carolina Lucas from the Department of Immunobiology from Yale University School of Medicine in New Haven, Connecticut. And she will talk to us about immunological predictors of COVID-19 severity. Thank you so much for accepting and talking to us.
So I hope you can see my screen.
Yes.
Just Okay, good afternoon, everyone, and thanks for the invitation and for the introduction. So I'm part of the Iwasaki lab at Yale University, and our lab is the lab with focus on the immunological aspects of viral infection. And naturally, with the impact of the pandemic, we quickly redirect the studies towards SARS-CoV-2. Today, I will talk about two studies that I have been working recently in which we characterize the immune response of hospitalized patients with COVID-19 and how the immune response correlates with disease outcomes and trajectory. And with that, also how immunological markers can be used to predict disease severity, for example. So first, just a very brief introduction of a few aspects of the viral particle structure. I imagine that everyone here is very familiar right now with these concepts, but as I'm going to point viral proteins and a few aspects of the virus during these presentations, I will just briefly pass and guide you through this introduction. So SARS-CoV-2 contains 16 non-structural proteins and 4 structural proteins, so the spike, membrane, envelope, and nucleocapsid. So from inside to the outside, the nucleocapsid or N protein form the viral capsid outside the genome, and the genome is further packed by an envelope which is associated with 3 structural proteins. So the membrane, the spike, and the envelope protein itself. So here, in addition to the structural proteins, you can also see the viral genome. That is a single strain positive sense RNA of approximately 29 kb, which is in general larger compared to other RNA virus. So as I will explore a little bit during this presentation, antibody response against the virus, specifically regarding neutralizing antibodies post-natural infections, I will just talk a little bit more about the spike protein. That is the region described so far by multiple groups as the main target of neutralizing antibodies. So the spike protein, as can see here, is a transmembrane glycoprotein that forms homotrimers that projects from the viral surface. And the S is composed of 2 subunities, S1 and S2. And the subunity 1 consists in the N-terminal domain and also the RBD or receptor binding domain that is responsible for the viral binding to the receptor on the host cell, the ACE2. And the subunity 2 comprise the fusion peptide and other domains as the transmembrane domain, cytoplasmatic tail. And basically, its functions of the S2 subunit is to fuse the membranes of the virus to the host cells. So on this right panel, you can see a 3D structure of the spike from its closed conformation to open conformation or up conformation. And this is induced by proteolytic cleavage in the furin site that is here indicated by the red color. So for all coronavirus, host protease cleave the site to activate proteins critical to fuse the membranes to the virus to the host cells. And here is also highlighted in pink the ACE2 binding site. So looking now at the disease, the COVID-19 disease, what we are noticing is this large variety of outcomes. So people that are exposed to the natural infection can be asymptomatic, yet others can have mild, moderate, or later COVID. We also know that some people will suffer from acute disease, while others will have this long hauler disease, which are the people that we discussed in the previous presentations that will have symptoms that can last from months to a year. So there are a lot of host factors that can dictate the outcome, ranging from age, sex, comorbidities, and pregnancy. And we have been studying in the lab different host factors. And today I will specifically focus on the comparisons between moderate and severe groups, exploring these host mechanisms of viral resistance. So talking a little bit about our cohort, for this studies, we enrolled 240 patients, COVID positive by PCR and ELISA, and we follow these participants longitudinally from 1 to 7 time points of collection. So these participants include non-hospitalized with asymptomatic or mild symptoms, and also hospitalized patients. And we also included in this data from vaccinated volunteers that received mRNA vaccines and were not previously exposed to the virus. As negative controls, we used healthcare workers, so 108 healthcare workers that were periodically screened for the viral infection and were negative by PCR and serology. So for the hospitalized patients, we stratify them by levels of oxygen supplementation and ICU admission. And you can see here in the base of the pyramid, We include the negative healthcare workers, followed by the moderate group with none or moderate oxygen supplementation, and severe patients that required ICU admission and high levels of oxygen supplementation or even mechanical ventilation. At the top of the pyramid, you can see like deceased patients, unfortunately patients that were not able to survive of the infection. For some of our analyses, instead of this classification by clinical severity, we also stratify patients by clinical outcomes, separating by discharge and deceased patients. So we did analysis of PBMCs and plasma samples, and we looked at the lymphocytes and myeloids populations, as well as cytokines, chemokines, and also the viral load and antibody response. So as I mentioned earlier, our idea was try to understand the host mechanisms of viral resistance, but also mechanisms of immunopathology. So first, we look at basic immunological markers. And here you can see like in green are the healthcare workers, and then we have in dark blue or red hospitalized patients, moderate and severe. And as this was previously explored by other groups, and at the time, we also showed that COVID patients present a marked reduction in the number and frequency of T cells, both CD4 and CD8, but we also noticed an increase in the populations of monocytes, neutrophils, and eosinophils. We observe also an increase in inflammatory cytokines like IL-1, IL-6, and interferons, and we then start exploring the cytokines profile. So we then found a cure COVID signature, and this COVID signature we have cytokines that were shared by both moderate and severe groups. And as you can think on this graph like a mirror, so you can see clearly that are cytokines that correlate positively with other cytokines, and the intensity is more intense, it's more purple, and you can see that there's these cytokines that are shared in the moderate and in severe groups. Here are representing only cytokines in the early stage of the disease, so before day 10 of symptom onset. But we can also see that there are some correlations of cytokines that are only presented in one of these groups, in moderate or the severe group. So this profile keeps changing over time, and over time, this difference are even more striking. So this suggests a distinct cytokine profile in moderate and severe patients. So trying to explore more deeply the cytokine profile and its correlation with the COVID trajectory, we did an unsupervised cluster analysis. And what we saw first is that this analysis separate our patients in 3 clusters, so cluster 1, cluster 2, and cluster 3. And each cluster include unique signatures of cytokines that we call signature A, B, C, and D. And for example, if we look at the cluster 1, so the cluster 1 comprise patients that express more of the signature A, and the signature A is related to a high expression of tissue repair factors and ground factors. And if we look, for example, for the cluster 3, in the other hand, they have a low expression of this signature A, but a high expression of signature B and C that are correlated with inflammatory cytokines. But what these clusters means? So these clusters show there was a tendency of old patients of falling in cluster 2 and 3, and also patients that stay longer at the hospital. But more striking what the clusters reveal was that, for example, was a distinct disease trajectory. So for example, patients that were falling in cluster 1, here represented in yellow, they have a better disease prognosis. So they have a better disease prognosis when compared with patients in cluster 2 and 3. And these we are measured by clinical score. So if you remember the pyramid that I showed at the beginning of this presentation, so clinical score 6 is indicating that, and clinical score 0, it's when the patient was discharged. So this was also measured by clinical complications, and we can see that patients falling in cluster 2 and 3, they have a higher levels of complications, as coagulopathies, and a higher frequency of mortality. So next, what we also noticed that elevated levels of specific inflammatory cytokines were at the early stage of the disease were related with the distinct clinical trajectories. So for example, here you can see interferon levels and also IL-1 and IL-6, and that high levels of interferon at early stage of the disease were associated with the worst clinical trajectory. So here in red are deceased patients and in blue discharged patients. So based on this analysis, we generate this biomarkers list that is correlated with lethality. So I'm not going to discuss one by one, but for example, if we look to the bottom of this list, we can see, for example, the levels of IL-18, interferon, and IL-10. Higher levels, increased levels of these cytokines are highly correlated with lethality. So together, this data suggests and indicates that inflammatory markers correlate with COVID severity and outcome. So we next start looking for the antibody response. And one important thing that we noticed that is almost everyone in our cohort mounted a virus-specific antibody response. So here we are showing the anti-S IgG levels and RBD IgG levels. And for example, 97% of our cohort mount an anti-RBD IgG. And the patients usually reach the peak of IgG around day 15 post-symptom onset. And the average of the antibody levels from uninfected control donors were used to determine this limit threshold. And you can see here by this dotted green line. So next, we also access the viral titers by measurements of nasal swabs, nasopharyngeal swabs. And here, each dot represents a patient in its maximum titer over the disease course. So interesting, the maximum RNA viral load presented by a patient during the disease course did not correlate with disease severity. So there was no difference between the viral load in non-hospitalized, the maximum viral load between non-hospitalized and hospitalized patients. So in contrast with this absence of correlation among viral load and disease severity, we did the analysis of the maximum antibody levels over the disease course, and we observed that hospitalized patients showed an increase in the levels of anti-S and also anti-RBD, and here you can see IgM and IgG. And here we are comparing, for example, negative controls, non-hospitalized with mild or asymptomatic, and then in different kinds of purples, you can see the hospitalized patients from moderate, severe, and lethal cases. So notably also within the hospitalized patients, the deceased patients, they didn't have these higher levels of virus-specific antibodies. So together, this data suggests two major points. One, antibody levels correlate with the severity, but there's a fundamental distinct aspect in the antibody response when we compare patients who survive and who did not. So as deceased patients didn't follow the same pattern, we next addressed whether the timing and not the level of antibody was different between discharge and deceased patients. So here again, you can see in light blue discharge and in purple deceased patients, anti-S and RBD, and this is over time. So the longitudinal analysis show that this distinct trajectory when discharge patients reach an early peak of anti-S and RBD, and this also it's faster than deceased patients. So here in red, we also include high neutralizing patients just as reference. So the longitudinal antibody trajectory in the trajectories between discharge and deceased patients is also consistent with the capacity of these patients to clear the virus. So discharge are more efficient in clearing the virus over time, and we can see a persistent viral load in deceased patients. And again, when we compare the viral load at the maximum of antibody level, so when that patient reached the maximum level of antibodies, what is the viral load for that specific patient? And we can see that the viral load is higher in deceased patients compared with discharge or high neutralizers. So because of that, our next question was the quality of the antibodies. So what is the kinetic of neutralization antibody? And we have questions regarding this neutralization capacity. Do all the patients are able to mount a neutralizing antibodies? So first, what we saw is that approximately 90% of our cohort, yes, developed neutralization antibodies. And then we can see here, for example, when we directly compare the levels, the maximum levels of neutralization antibodies in our cohort among disease and discharge, these levels are similar. There's no statistical difference. And this is also comparable to individuals that were vaccinated and received one dose of the vaccine, here in dark blue. So this is 28 days after the first dose. What we also notice is that the levels of vaccinated people here in dark green post the second dose, it's comparable to our high neutralizers, so that patients that acquire this natural infection. But so going back to our cohort and comparing discharge and disease, we can see that the magnitude, there's no statistical difference in the magnitude of the antibody response, but what about the timing? And importantly, again, our longitudinal analysis reveal a faster neutralization kinetics in discharge compared to disease patients. And here, this is represented by the plaque reduction, the PRNT50s. And what exactly that means? That, for example, a discharged patient reached 50% of neutralization at 1 to 90 titer on day 9 post-symptom onset, while the diseased patient will only reach that same titer 2 weeks later. So finally, we did the same kind of analysis we did for the cytokines, and we asked whether the timing of neutralizing antibodies production will correlate with disease trajectory. So to that end, we stratify the patients in early versus late neutralizers, here shown in pink and green, and based on neutralization activity before or after day 14 post-symptom onset. So what this data here is showing that early neutralization activity did not correlate with age, BMI, or gender, but neutralization activity correlated with the clinical trajectory. So early neutralizer have an improved clinical size compared with late neutralizers. And again, this is the same way that was represented in the pyramid. Here is the x-axis is the clinical scores over time or collection time points. And the early neutralizers also presented a lower mortality than late neutralizers. And the maximum viral loads reached over the disease course were lower in early compared to late neutralizers. So these data indicate that the clinical trajectory and the outcomes do not correlate with the level of neutralization, but rather with the timing and the kinetic of neutralization antibodies productions. So just to summarize, we observed that persistent viral load is detected in severe patients. The viral load drives inflammatory cytokines, and the cytokines profile is distinct among severe and moderate patients. We showed a 4 signature of genes that can distinguish patients who recovered compared with severe disease, and the levels of inflammatory cytokines at an early stage of the disease can predict severity and mortality. Elevated anti-S IgG levels were associated with worse disease outcome. Deceased patients presented a delay in development of virus-specific antibodies and viral clearance, and the clinical trajectory correlates not with the levels, but the timing and kinetics of neutralization antibodies. With that, I would like to thank you all for the attention. Of course, everyone that contributed to this study, and also my lab, and of course, my supervisor, Professor Kiko Iwasaki. Thank you very much.
Thanks so much, Dr. Carolina Lucas, for this fantastic set of data. And we now go to some debates. We have quite a few questions here, but I will make my use of my privileges as a chair to ask the first one to Dr. Carolina Lucas, because you just said about viral load, and I always keep asking whether you can measure viable viral particles versus just fragments that cannot really infect the patients, or I don't know if this is a let's say naive question, but I think we can start the debate on this.
Oh, no, definitely that's not a naive question. It's very important. And the data that I show when I was showing the data was about RNA. So definitely did not indicate that is an infectious particle. But we haven't tried for the entire cohort, but yes, we test for several patients. We did test, and especially patients that stayed longer at the hospital, we were still seeing infectious particles. So for some patients that we call like that they have persistent, we did in fact, we checked by plaque assays and we could detect infectious particles.
Okay, we have a couple of questions here. I'll start with questions from Professor Geraldo Souza, professor from our emergency department. And he asks, are there markers of this at the disease beginning that could identify patients that would develop late symptoms? I mean, we saw quite a few indicators, but which one you believe is the most significant? Can go very fast on this. Maybe we start with Regis.
This is a very interesting question, and I think it's what all researchers in the world are trying to find. This is an important answer in order to facilitate screening of patients that increase the risk for long COVID. But this is a difficult task because disabilities after COVID, the long COVID, is a heterogeneous group of manifestation. There is a lot of noise regarding what is the effect of critical illness, what is the effect of chronic disease and comorbidities, and what is the specific effects of the virus. What I can say right at this moment, it seems that severity of the acute episode of COVID correlates very well with the risk of presenting long-term limitations regarding physical health, regarding mental health, and probably regarding cognition as well.
I don't know if Catherine can add something.
Of course, it's a very important question. I think an important way to think about it is to step back from the question of causation. So what exactly does COVID cause in the long-term symptoms, but instead to ask what problems are your patients going to have? Because we know many of the patients come into the hospital with depression and anxiety and substance abuse disorders and frailty and disability. So the first is to really understand what problems your patient already had, because they're going to be worse. So that's the easiest prediction, is the things that already are there. But I think certainly in the American population, for example, a third of our hospitalized patients are already presenting with significant disability and comorbidity when they first come in with COVID. And indeed, these are risk factors for the disease. So I think that's the easiest one. I agree with my colleague here that the duration of critical illness, the severity of illness do seem to map to muscle loss, to inability to walk, to probably more disability there. I'm not as sure that they map as well to many of the psychological manifestations. I think just like we've seen in post-ICU work, that it probably doesn't matter how sick you are when it comes to depression and anxiety, for example.
Francisco, may I add a quick comment?
Yes, of course.
I agree with the previous answers, and what I would add is a comment on the samples that are being presented here today, because we are showing data about hospitalized patients. In our case, at Hospital das Clínicas, it's almost a ceiling effect of symptoms of patients with very severe disease. And if you look at other kinds of investigations, for example, a paper that was published in Nature Medicine as a letter a few weeks back, the approach is completely different. There's a mobile phone application that people use to answer about long COVID symptoms 6 months after discharge, 6 months after resolution of symptoms. Not necessarily people who had been hospitalized, people who might have had mild COVID-19. And the rate of reporting symptoms was just above 2%. So I think there's a very clear message from the presentations and the literature that the patients at the highest level of severity, they are going to show a plethora of symptoms of different kinds and different possible causal influences. It's a mixture of several forms of persistent manifestations, I guess.
Can I ask our clinical colleagues whether there are studies comparing the outcome of COVID, just the way that is being done from all your groups, with other forms of intensive care unit internation, like other forms of ARDS, for example, or other viruses? I mean, is there something special about COVID, or is it just that COVID is, some cases of COVID are really serious?
I can start that one if you'd like.
Yes.
I think both are true. I think the special thing about COVID is that hundreds of millions of people have it. And so we're going to see a range of symptoms that we haven't seen before, and we're going to see a symptom prevalence in less sick people than we've previously recognized. So I think that's the most dominant effect of COVID. I think there are some unique sequelae that perhaps we don't see as much with other things, such as persistent issues with smell, maybe how that then affects how a patient eats and how they regain muscle mass, for example. So I think there may be some very interesting COVID specific. I think the majority, though, of these symptoms look just like recovery from many other both bacterial and viral pneumonia recoveries. Within our PEDAL network, we've done, just like BRICNet and others have done randomized trials amongst patients with sepsis and ARDS that we've also done post-hospital follow-up. And so we built the Blue Coral study to use many of those same instruments so that we'll be able to compare the cohorts.
Regis, go ahead.
Geraldo, please, Geraldo.
Thank you. I was just going to mention two things. And one is that we agonized about the issue of whether recruiting a control group or not, and the situation is still very complex to open another arm of investigation and then bring people to hospital for in-person visits. So we haven't decided about that yet, but we haven't been able to do that so far. But talking about psychiatric and neurological manifestations, about 4 weeks ago, the Lancet Psychiatry published a paper with data from electronic health records, and they did comparisons with influenza and other respiratory infections. And there, I don't know, I can't remember now exactly the figures, but the difference is very, very clear towards more frequent and varied symptoms for COVID-19 compared to influenza and other infections. Very, very clear.
Regis.
I would add that most studies that I read comparing ARDS due to COVID with ARDS to other conditions use historic controls, and we live in a different moment related to ICU organization, related to hospital organization. We have a such high strain healthcare professionals with burnouts. The ICU bed availability is not the same. So we have a different moment, and I have some concerns regarding some historic comparisons, because we live in a different moment, especially in context, especially in low and middle income countries, that we faced a lot of challenges related to organization of care.
Okay, we have a couple of other questions. One question from our research agency is whether the long terms seem to be related to the use to the mechanical ventilation. That's what we saw from the coalition data, especially, but also from the other presentations. Can we think of whether we see just the reflection of a more severe disease, or are there direct effects of the mechanical ventilation that influence the long-term outcome? Let's say some kind of sequelae or something. So maybe Regis, you showed this first.
Okay, this is a very interesting topic and sometimes confusing, because people are thinking, okay, mechanical ventilation can cause long COVID, and it's not necessarily true. Mechanical ventilation is a proxy of severity. And of course, it is an important treatment to save people's lives during the acute phase of disease, of severe disease patients with acute respiratory failures. Mechanical ventilation is an important treatment. And of course, there are some parts of the treatment that can cause long-term effects. With pay attention at the definition of post-intensive care syndrome is related to new or disabilities or worsening disabilities related to the acute severe disease, or the treatments used to save the people at the acute moment. And of course, people who need mechanical ventilation, they need sedatives that are risk factors for PTSD. They need to use neuromuscular blocking agents. Sometimes that is a risk factor for ICU-acquired muscular weakness that can impact physical functional status. People with prolonged mechanical ventilation, they can have laryngotracheal injuries, and also problems with swallowing. They can suffer from some aspirative pneumonia after. But I think the most part of the effect is related to the severity. Mechanical ventilation is a marker of severity of disease, and this severity alongside with the specific effects of COVID-19 can cause long-term consequences for survivors.
Does someone want to add something? Okay, thanks. We have another question from Ricardo Luis Smith. It's a kind of long, so I'll make it short. He cites different examples of patients with neurological outcomes, but then he cites another example in which the patient might have relatively moderate disease, and then later on starts to present muscle weakness. So is it possible or frequent to differentiate between a neurological and neuropsychiatric symptom versus a myopathy? I mean, is it quite common? How common should one pursue this after COVID-19? Maybe Geraldo can focus on that.
It's an interesting point, and I'm thinking of on how to best address it. And perhaps the best thing to do is to think about what has been happening here. And this multidisciplinary approach has allowed several groups to look at the same patients with different instruments. And of course, today I was talking about neurology and mainly psychiatry. I'm a psychiatrist by trade, actually. But we have a very strong team dedicated to functionality and rehabilitation, led by Professor Lina Mara Battistella. And they have a very nice battery on several aspects of physical functionality, including muscle ultrasound, and also objective assessments of muscle weakness. And the severity of symptoms using those assessments is very clear. And there is some degree of relationship with the severity of the disease again, and admission to ICU care. So there is a range of symptoms that may have different causes. And I don't know if that answers the question that was posed, but I wouldn't at all say that some of the things I mentioned today, they belong to neurology. We have evidence that this is a wider kind of problem, including musculoskeletal difficulties over time.
Yeah, we have.
I'm not sure I completely understood, but I will make a couple of points anyway. So the first is, it would be very unusual to develop weakness late that wasn't already present early in the disease course. If we're going to call this any of the acute illness associated neuropathies or myopathies and atrophy that we're used to seeing with patients with acute inflammatory illnesses. Can that still be related to COVID if it happens late? Sure. There are new onset inflammatory myopathies, Guillain-Barré type syndromes. I mean, these have been associated with COVID, but are very, very rare. And I think it's hard to tell. But the important point I wanted to make, though, is that new things happen too, and that COVID's not the only thing out there. And we're starting to find in our post-COVID population that a patient after COVID develops a new symptom and everyone calls it COVID. And then they wait months until they get into a post-COVID clinic and find that no one's diagnosed their cancer that's associated with this, paraneoplastic syndrome. So just the reminder that if it's atypical, that it might not just be COVID.
That's a very important remark. Thanks. We have another question from Geraldo Souza. Why the severely ill patients, that's probably to Carolina, have the specific signature? He asks whether there could be a genetic component or a difference in the recognition pattern of receptors. That's a tough question.
I don't know if I completely understand the question. But yeah, so the way we did the analysis was a little bit different. As I showed, for example, what we did was we let a program decide for us how to group the patients. So we didn't know the identities of the patients, and we just tried to cluster. And it suggests that these patients share this kind of identities. Definitely, then we can do analysis in that clusters, and that is very important. And again, we didn't have the data to do all kind of analysis, but as I showed before, of course, there was things like age, gender that could directly influence. We didn't notice a significant difference among that clusters, but definitely there are other things that could influence. We just checked the basic, maybe the surface, but definitely there are other host factors, and this could be genetic, and we didn't have that kind of information, but based on what we have, I could say that was not specifically like related to gender, to sex, to age. That was the major factors that were correlated with severity or also other comorbidities. I don't know if this answered the question, but I don't think I have exactly also an answer for that question.
Okay. Yeah, that's I know that many groups are looking for genetics of COVID-19 response. Here we have another question, probably from a cardiologist who doesn't identify herself or himself. To Catherine, are the cardiopulmonary symptoms you see more related to heart or more related to lung? That's an interesting question.
Yeah, so important question. We know, of course, COVID-19 is a multi-system disease. I think especially early in the pandemic, in the first few months, we talked a lot about the cardiomyopathies, for example, that we were seeing in our patients. Of course, we have all of the problems with clotting as well. I think that within our study, we don't have the data to answer that question yet. We do know that pulmonary manifestations that linger seem to be more common than cardiac. That residual fibrosis, for example, is quite common. So my guess is the majority is pulmonary, but it doesn't mean that there's not a very important group within that that has either persistent cardiomyopathy, perhaps that has pulmonary emboli and maybe right-sided heart dysfunction associated with that, or even new myocardial infarctions that happened perhaps during the acute disease. So an important area to continue to study.
Great, thanks. We have another question to Carolina from Katie Souza Santos. She asks, for how long have you detected viable SARS-CoV-2 RNA particles? Have you looked at IgA levels and severity, and disease severity?
Yeah, so we did the collections for viral load with an interval of 4 days. So this really depends on the patients that stay longer in the hospital. So we did access, but we also separate, and we have a group of patients that that have persistent viral load over the time, and we could detect viral load in a few patients, very few patients, for over than 45 days. And this was not only RNA, but also through plaque assays. But this is a few portion of our patients. Almost all of them can completely clear the virus much earlier than that, even for hospitalized patients. And yes, we measure the levels of IgA, and the IgA levels, they follow very well the levels of the IgG. And we are also addressing the levels, the IgA, for example, in the saliva. And they correlate very well, and they correlate also with disease severity. And specifically for disease severity, what we saw was anti-S, so not RBD, and this is also described by other groups in literature. So just to be more cautious, we are only correlated severity with the anti-S, anti-spike, and not specifically against the region of the RBD.
Thanks, Carolina. We have another question from Lucia Rossetti Lopes, and that's probably for all of the speakers. Are any markers that relate to severity of disease in children? Do we have data about that?
Could you please only repeat the question, the last part in?
Are any markers that relate severity of the disease in children? Do we have data in children in these databases that we discussed here?
The Institute o Instituto da Criança, com Professor Clovis and Magda Sampaio, they have a cohort of patients who were hospitalized. And I'm only here advertising their work. I wouldn't have an answer for that, but I think they should be called to another symposium because they certainly have very interesting data on that.
Yeah, there are some places in Brazil with an unusually high severity of disease in children. I am not sure we know why. Whether it's socioeconomical or there is something else going on. I don't know.
Yeah, I was just going to say that the Polisi network in the United States, it's sort of the pedal partner network, is certainly doing some great epidemiology work in this space too. So I would invite them to the follow-up symposium. I'm personally interested which of the viral variants may be most associated with disease in children too. It sounded like the reports were that the P1, for example, led to more disease in kids, but I certainly don't know any of the science.
Yeah, in our cohort, for example, we haven't included children, but based on literature, and I can also just answer about immunological aspects. The immunological aspects in children and in adults are quite different. And so far, I know that some cytokines, for example, like IL-17, have been related as, for example, markers of severity in children, but there are more specific markers, but definitely the immune response is different, and even the way of classifying severity is also different in children.
I think this question is important also to emphasize the needs for study other populations than only hospitalized patients. We need to study old patients, children as well, in order to understand the possible impact of virus on long-term consequences. And also, as we are discussing here, it's still important to study causality, because it's, okay, we are saying there is long COVID. I like the term the WHO uses, the post-COVID condition, because it doesn't imply causation, and it is a hot topic. We need to study the causation, because in other way, people will say, okay, any problem after COVID will be described as a post-COVID problem. So it is important to determine and to study causation as well.
Actually, do we know the exact incidence of COVID in children? Do we have reliable data about that? Because I don't think we have really large number of data that have addressed specifically that. I don't know if any of you have any data about that. I don't think so. Yeah. Great. We have another comment by a colleague from Rodolfo de Paulo Vieira from Federal University of São Paulo in São José dos Campos. He has more than 400 post-COVID-19 patients from different severities being followed with several ailments every 45 days. And they are engaged on a multidisciplinary rehabilitation program. Sorry, Rodolfo, I'm editing your question because in the interest of time. And I think this calls for the need to a multidisciplinary approach to take care of these patients. I think the huge effort that our hospital, for example, has done to the acute phase of the disease now will have to turn, at least in part, to multidisciplinary care of these patients, because several of them will need cohort, and I think this is a challenge for that. Maybe Geraldo can comment later on what can be done on this in terms of organization to better serve these patients.
I think that's a very important point. And in fact, the motivation to get our groups to collect data together was of course, the fact that the disease is a multi-organ, a new multi-organ disease, and also an opportunity for people to interact with each other. We have just had an example of the questions about myopathy, which is of interest of several groups. What I can say about the experience here is that there is not, we haven't actually organized a post-COVID clinic. The patients who accepted the invitation, based on the main manifestations or the most urgent needs, they were allocated to the different groups involved in data collection. But we hope that based on the final analysis of the data and the multidisciplinary discussions, we will be able to have insights on how to better organize services. There is one. I'm sorry, but there is one comment that I feel that we must do in a symposium like this is about vaccination as well. I'm sorry to be a bit off the question, but we have been talking about the need to save lives through vaccination with no further delays. And we are talking here about severe COVID and long-term consequences after 6 months. And we should also think of the importance of vaccination to prevent severe cases of long COVID. As a Brazilian, I think we have to think about that as well here. I'm sorry, that was a comment beside the point, but I couldn't avoid making it.
That's a very interesting comment, Geraldo, because one question we have here is whether there might be a therapeutic, let's call it therapeutic, effect of vaccination on long COVID. There are some anecdotal reports that people who got vaccinated improved on their symptoms. I don't know if you have any comments about that.
I would leave that to Carolina. Maybe she has something interesting to say about that.
Yeah, this is definitely something that we are studying, but we don't have the data yet. We saw this data. There's definitely some people improving after getting vaccinated, long haulers improving after getting vaccinated, and this is something very fascinating. Also suggests some immunological relationship with this. So it's definitely something that we are trying to do, but we still don't have the answer. So I think, again, it's very important to prevent the disease, to vaccinate. We also know that it's important to get vaccinated. It's beneficial for people that are suffering with long COVID. And we still need to understand the cause of this long COVID. So I think based on these presentations here, we saw that this could be related to a persistent virus, not exactly infectious virus, but RNA. This could be related to autoimmunity. This could be related to different ranges of different areas. So we still do not understand. And I think more than a therapeutic thing in a therapeutic right now, we know that this vaccine is beneficial. And it's important to get vaccinated right now.
Thanks for this. One question, I will rephrase it a little on my own interest. Which is the central cell which is the most, let's go, they ask here, what is the most important cell in COVID? I would say, what is the central cell? Let's say the neutrophil, the neutrophil seems to be particularly important, or maybe lymphocyte subsets, or the pulmonary alveolar cell, or as my own interest, I put the endothelial cell as well. So I won't say the most important, but probably the cell which determines whether the disease will be severe or not, if there is one, of course.
I think this can be a long fight if each one picks the cells here. Of course, there are cells that at the beginning, this can have this bifurcation in a severe, but if I need to choose, I will say that the B cells are essential. The cells are essential to produce antibodies, and the antibodies are what we know right now that can control the infection. So I will say the B cells. But of course, if we are thinking at the beginning at the infection and cells that can cause damage, we'll have neutrophils, and we can also have macrophages. But if I need to pick one, I will say the B cell.
Yeah, okay.
From our point of view, I would vote not for the neuro, but for the endothelium.
The endothelium in the central nervous system.
Absolutely, yeah.
or in the lung, maybe.
Yeah.
As the pulmonologist, I guess I have to vote for the pneumocyte.
Yeah, that just shows how systemic the infection is, and it's very hard to separate cause and consequence in such a severe setting such as COVID-19. Maybe I'll open now, if any people from the table, if you want to discuss something or to ask a question to some other. I still have one question that I'm saving to the end here, but
I do have one question for my colleagues and for you. We've talked almost exclusively about observing these phenomena, but not about intervening and seeing what actions we can take other than, of course, vaccination, which is by far the most important. But what can we do to help these millions of people who are suffering? And there was a mention of COVID clinics, for example. It seems to me that most of the activity that we're seeing in the post-COVID space is not research when it comes to interventions. And so I would love to know what's going on in Brazil, for example, to actually learn which interventions may improve long COVID.
Thanks. This is a very, very nice discussion here. Yeah. Maybe Geraldo and Regis can comment on this.
Você vai, Regis? Depois eu vou?
Can be. This is an interesting question. I think independent of the cause of the patient suffering, it is very important to give support, independent if it's related to critical illness or specific effects of COVID, or if it's related to a chronic or a comorbidity, chronic condition or comorbidity. We need to evolve in the way we provide care for our patients after hospitalization, for example. And if we can take something positive from the pandemic and long COVID, is the fact that we are paying more attention on our patients that have consequences after an acute severe disease. And as we know, in the past, we had these problems with other etiologies of ARDS, and our patients need support, need rehabilitation. And this is very important because we need to evolve our research in order to find effective ways to provide an effective rehabilitation for our patients. And I think this is a priority topic right now, and especially in Brazil, in a low-income country, our focus is on the acute scenario, is on short-term outcomes, and we need to study ways to provide an effective treatment for long-term, for improving long-term outcomes. This is very important. Unfortunately, COVID is a very recent entity, and I think we are not studying specific treatments for long COVID, but I heard about some initiatives that are studying ways to provide rehabilitation strategies, such as physical rehabilitation, cognitive rehabilitation, psychological rehabilitation for patients after COVID. Geraldo.
That's a very nice outlook on the issue, Regis. I would add, I would again reinforce that in this first wave of data collection, the main problems were identified, and this has encouraged some of the groups to start, for example, programs for physical rehabilitation, as I mentioned before. At the Institute of Psychiatry, there is an initiative for cognitive and psychological rehabilitation as well. And since we are here in FAPESP symposium, I would add that we have very concrete plans to ask for funds to a second wave of investment on this cohort that we organize here, and do nested interventions, learning from the experience of the first wave. Everything is evolving so quickly, but there's a clear need for investigations on specific forms of interventions that can be effective. And the last thing I would add is that sometimes I fear that when we show the amount of symptoms and disabilities, there is also a risk of having a kind of negative or pessimistic view, which could affect the way patients will see themselves. And I haven't got that at all. I think science and attention and care to the patients. And there's lots of rehabilitation strategies that have already been promoted and devised before that can certainly be applied to these patients with a positive view on their outcome in the long term.
Yes, from all the data I saw, especially the early data Regis presented, we see that there's a lot of room for improvement. For example, from 1 to 6 months. Okay, some people stay with symptoms, that's definitely, but quite a few patients improve on their scores. Have you taken a look, Regis, between the improvers versus non-improvers at 6 months? I mean, what can you determine who improved and who did not improve over 6 months?
This is an interesting question, and it's our plan of analysis includes to analyze what are the predictors of improving at long term. As we have an ongoing study, we just made a few analyses in order to show these data for these events, but it's an important topic, but unfortunately we did not analyze in this way at this moment, but it's an interesting point, and I'm afraid that we'll lack some meaningful factors to analyze because we are conducting a very pragmatic study, that is a linkage of 5 randomized clinical trials. So we needed to standardize it, some variables, some pragmatic set of variables in order to have a feasible study. So I'm afraid we won't have some specific variables that of high value to predict improvements at long term, but it's a very important question. And I would add to the last question, Geraldo was talking about rehabilitation, and I think one great priority is to recognize patients with disabilities of such severe disease as COVID, because many mental health disabilities, for example, are usually underdiagnosed and have a huge impact on quality of life or survivors. And this is very important to recognize disabilities, physical, mental health, and cognitive disabilities after an acute critical illness such as COVID.
I think it's an interesting flip side to the concern that when everyone hears how horrible recovery is, that we'll all get even more depressed. But we know from the post-ICU work that most patients feel so much better to understand that what they're experiencing is common among others as well.
Yeah, that's kind of universal for other things as well. Yeah, it's interesting. Well, I think we are coming to our end. But before, I would like to have 1 minute for one question, which is kind of difficult. It's from Paulo Scarzoni, a postdoc from the Psychiatry Institute. Her question is more general, and it's not very easy to answer in a few minutes. I guess I am the guy who had to answer this. We are talking, she says, we are talking so much about science, this pandemic, but how much has our Brazilian science been affected? And how is the funding for this period, especially for projects about COVID-19? That's a very, very important question. And it's not very easy to answer. There are several. I used to say we have several Brazils. And for one Brazil, one kind of Brazil, we do have money, and I'll come back to this. The other Brazils don't have money, especially from the federal government. We have that has really cut severely on the funding for our National Research Council, and certainly this is going to suffer. But even so, there are a few initiatives for vaccination and so on. The good part of Brazil, let's call it that way, are projects from FAPESP who have supported a lot of research. I guess, of course, we always can say, we could do more. Of course, we wanted more, but FAPESP has given a lot of support for the development of the vaccine, for studies, epidemiological studies, and for special grants about COVID-19 since the beginning of the disease. And of course, the other problems, health problems, still linger on, so we cannot concentrate everything on COVID-19. In our own group, we discussed whether we should switch to COVID, and we decided we would not, because we still have urgent things to do, and we would waste our efforts, and we had to keep our research going on. But several other groups who have more to do with COVID have switched to COVID, and they have found some support from FAPESP especially. And I think there is some support. There might be better support. We always wanted more support, yes, but I think that the picture is quite heterogeneous in this regard. And with this, I really want to thank again our speakers for this wonderful presentations and discussions. I've learned a lot today, and I think we have fomented our research questions to advance into our research or patient care, especially. And I'm sure that this kind of initiative is very important to keep fighting COVID-19 and other diseases as well. And this multidisciplinary approach is absolutely needed to advance on disease understanding and therapeutics. So with this, I want to thank especially our foreign speakers, Catherine and Carolina. You are Brazilian, but you are at this moment you are foreign, and but also our speaker from semi-foreign from another state, Regis from Rio Grande do Sul, and our in-house speaker, Geraldo. Thank you so much for these wonderful presentations. And with this, I thank all the audience for the stimulating discussion, and wish you a good afternoon and productive rest of the day. Goodbye.
Thank you. Bye-bye.
Bye-bye.